Hello and welcome to BIOC211 Pathology and Clinical Science 1. This is Lecture 1 Part 1 and today we're going to look at Introduction to Cells and Disease. So our session learning outcomes today are common clinical terminology, the definition of disease process and the concept of clinical medicine. So firstly, we need to have a look at what health actually is. So health is at one end of a spectrum with disease being at the other end. So health is actually defined as a state of complete physical and mental well-being. So a healthy person is really capable of living a happy, productive life without having any physical, mental, emotional turmoil or disabilities that will limit their ability to live an active and happy life. So when we're looking at health, we also need to look at disease. And pathology is the study of disease. Pathological abnormalities present with certain signs and symptoms. So pain, weakness, altered vital signs. And when I say vital signs, I mean heart rate, blood pressure, body temperature, respiration rate. These will be altered when you have a disease state. And also you need to look at the alteration of quality and quantity of body fluids, such as blood, urine, cerebral spinal fluid. So what exactly is disease? Now this is at the other end of that spectrum, and disease is defined as an acute or chronic illness that one acquires or is born with that causes physiological dysfunction in one or more body systems. So generally disease has very specific signs and symptoms, and these characterise its pathology or its identifiable etiology. So these diseases are conveniently classified into the following large groups. Congenital and hereditary diseases. So these are a result of developmental disturbances. They can be due to genetic abnormalities. They can be chromosomal abnormalities. They can also be intrauterine injury, and these can be due to exposure or viruses or exogenous toxins. So I think one that's really well known is listeria, and this is what is found in the soft cheeses and raw fish, and this is one of the reasons why pregnant women aren't allowed to have these foods, because they can cause damage to the fetus. So inflammatory diseases are often caused by microbial agents or allergens. A good example of that is hay fever, asthma, food allergies, and anaphylaxis. So this is a severe acute inflammatory response to an allergen or a trigger. Degenerative diseases. These are diseases that cause a degeneration to a specific part of the body. So for example, osteoarthritis causes degeneration to the joints. Atherosclerosis can cause blood vessel degeneration, and Alzheimer's or dementia can cause brain degeneration. Metabolic diseases. So diabetes is probably one of the most well-known metabolic diseases, and also diseases that affect fluid and electrolyte imbalances come under that metabolic category. And the last category is neoplastic diseases, and these are abnormal cell growth diseases such as cancer. So what is clinical medicine? So the word clinical pertains to the bedside or to the clinic. So this is the study of medicine that is founded on actual observation and treatment. And this is needs to be distinguished from theoretical or basic science. And the term medicine is the art and science of the diagnosis. So treatment of the disease and the maintenance of health. The treatment of a disease by non-surgical means, and this is also pertaining to or founded in actual observation and treatment of patients, and as distinguished from other theoretical or basic sciences. So clinical medicine is the diagnosis and non-surgical treatment of disease based on what is actually happening in clinical situations. So why do we need to learn human clinical science? We need to understand how the body responds to disease. So the body can respond in different ways depending on various factors. So does the person have any comorbidities? And when I say comorbidities, I mean other diseases that may be impacting on the disease that you're looking at. So how do these different disease states impact each other? We're looking at genetic factors, so are there predisposing conditions, genetic conditions, that give this person a higher chance of certain diseases? And what's their general health like? How robust is this individual? Are they fit? Do they have a great diet? Do they get sick easily? All of these sorts of things. Now, understanding how these modalities applied will interact with normal bodily processes is really important. And we need to look at Western modalities as well as conventional modalities, because all treatments, whether they're medical or natural, will interact with normal bodily processes. So at any one time, patients may and are most likely consulting more than one practitioner. And there's been a lot of research about what's known as polypharmacy. So this is people who are taking more than one either pharmaceutical medication or nutrient herbal supplementation, and if they're not managed carefully, they can cause life-threatening interactions. And the scary thing is that a lot of people don't disclose this to their health practitioners. So it's really, really important to identify these drug herb nutrient interactions. And one really important aspect of that picture is making sure that health practitioners have really good communication regardless of the modality. So one thing that I would really like to highlight the importance of in this lecture is that as whatever modality you go down the path of, it's really important that you have a lot of respect for other modalities and that communication is there if you're working with a mutual client. So we need to be able to understand that we're not able to cure everything. We're not allowed to able to treat everything. And we're just one little tiny cog in a very big wheel that is the healthcare system. And so we may be working with medical doctors, physiotherapists, chiropractors, osteopaths, acupuncturists, naturopaths, nutritionists, psychologists, psychiatrists, occupational therapists, counsellors, and the list goes on and on and on. Now, as we begin each new section, we're going to go through, when I say section, I mean the body systems that we're going through in this subject. We need to spend a little bit of time reviewing each of the anatomy and physiology in each section. And so today we're going to start with the immune system. So let's have a little review of the lines of defense of the immune system. So as you can see, this is broken into two sections, so non-specific immunity and specific immunity. And the first and second lines of defense fall under that non-specific immunity. And so skin and mucous membranes are the primary line of defense for our immune system. The second line of defense is antimicrobial proteins, macrophages, natural killer cells, non-specific cellular responses, and fever and inflammation. Now, the third line of defense, this is where it all gets a bit complicated and tricky. So hopefully you have a good understanding of this already, but I'll try to just give you as brief as possible summary so that we're all on the same page. So T cells are cell-mediated immunity, and B cells are humoral or antibody-mediated immunity. So T and B cells are types of white blood cells. They're lymphocytes, and they originate in the bone marrow and then they mature in the thymus gland. So T cells, let's start with them, they're usually classified as CD, which stands for cluster of differentiation cells. And this is a system of identifying cells based on what molecules are present on their surface, as this can determine how the cell mediates various immune system responses. Then we move to CD4 helper T cells, and these respond to processed antigens that are presented by the MHC, or the major histocompatibility complex class 2 molecules. So CD4 helper cells respond to the MHC class 2 molecules, and those molecules are found on antigen presenting cells, or APCs. So an example of those are dendritic cells, macrophages, B cells. And these respond to extracellular or exogenous antigens, such as various types of bacteria, including Staphylococcus, Streptococcus, Pseudomonas, Escherichia, or E. coli, as it's most commonly known. So then CD8 are known as cytotoxic T cells, and these respond only to the antigen complexes with MHC class I proteins. And these recognise peptides that are presented by MHC class I molecules that are found on nucleated cells. So it's very important for immune defence against intracellular or endogenous pathogens, and some examples of those would be chlamydia, Mycobacterium tuberculosis, salmonella, and this can include different varied viruses and bacteria. And these CD8 cytotoxic cells are also very key for tumour surveillance. So let's move on to the B cells. B cells are at the centre of the adaptive humoral immune system, and they are responsible for mediating the production of antibodies. So antigen-specific immunoglobulins that are directed against invasive pathogens. I know that was a lot, but you won't need to know all of that detail. But hopefully, it's a good summary, so that when we move on to the disease states, it's a bit clearer. Now, okay, immunological memory. So this is measured through the amounts of the antibodies in the serum, and we're looking at two different types of responses: a primary and a secondary response. And this is mediated by these memory T cells and memory B cells. So they form upon the primary response, and then the memory T cells and memory B cells, and then because of that memory, they are able to respond rapidly on the second exposure of an antigen. So, for example, in the primary response, IgM and IgG, these are two types of antibody secreting plasma cells. So in their inactivated state, B cells express IgM. And once they're activated, they can express different types of antibodies, including IgA, IgE, IgG, or they can retain their IgM expression. So what we see in that primary response is a slow rise first in the levels of IgM, and then the IgG also have a slow rise slightly afterwards. And then the initial contact, if you look at, there's a little graph coming up on the next slide. And after that initial contact, the antigen, it's followed by a decline of those immunoglobulins, the IgM and the IgG. So then the secondary response, this is accelerated because these memory cells have the memory of this antigen. So when that second exposure happens, there's a more intense response of those memory cells, and it rapidly increases the IgG antibodies. So this provides the basis for vaccination against certain diseases. And let's move on to that little slide. The graph, here we go. So I'm going to try and get my cursor over here for you. Here we go. So this is your IgM response, and then see how this is the primary IgM response and the primary IgG response. See how it's just a couple of days afterwards. And they come up to this lower level and then they drop back down. And then upon this second exposure that's happening around 28 days, these memory cells shoot up. Oh, hang on. There we go. They shoot up through the roof, the IgG one does, and the IgM has a little slight jump, and then it drops back down. So an example of this immunological memory is Epstein-Barr virus. So this is one of the viruses that is identified in glandular fever or chronic fatigue syndromes. And what you see when you look at blood tests, testing for the Epstein-Barr virus and the antibodies, they will generally measure the IgM and the IgG. So if it's a positive IgM, it says that there's a current or very recent infection. If the IgG is positive, it means that the person has had Epstein-Barr virus at some stage in the past. And if the IgG is negative, it means that they've never been exposed to that antigen before. Okay. So let's move on to medical and clinical terminology. So first of all, let's talk about signs. So signs are an objective evidence of a disease as seen by the clinician. Now, the symptoms are the patient's going to tell you what their symptoms are. So this is the explanation of what's happening, how it's happening, when and where it's happening. And there are 7 attributes of the symptom. So let's work through these. And I'm going to use reflux as an example while we're going through each of these 7 attributes. So location, where is it? Does it radiate? Is the pain referred? So for reflux, someone might say they have pain in the chest and it can radiate to their throat. Secondly, its qualities. What is it like? What kind of pain is this? Is it dull? Is it an ache? Is it sharp, stabbing, throbbing, etc.? So for reflux, people often describe it as a burning quality. With quantity and severity, how bad is it? So I'll often use an out of 10 scale in clinic, and it gives you a really good basis for measuring what the perceived severity is of this symptom, and it also gives you something to compare back with next time you see that person, so that you can see whether it's improved or worsened. And you can use this with the quantity or severity. This could be about how severe the pain is. It could be how often it's happened, how long it's lasting. Now, timing. So when did or does this symptom start, and how long does it last for? How often does it come? Is it associated with other factors? So with our reflux example, someone might say that their reflux is worse 20 to 4 minutes after food. It lasts an hour. And we'll move on. There's quite a bit of overlap in these symptom attributes, so we'll just move on to the next one. Factors that make it better or worse. So for someone might say that having a drink of milk helps to relieve their reflux. And another example, say a hot pack may relieve musculoskeletal pain. So other things that people often say with reflux are, it's worse when I eat spicy food or when I drink alcohol. It's worse when I lie down, which moves us on to the setting where it occurs. So when this symptom happens, what sort of environment are people in? Is it a hot day? Is it a cold day? Is it a season? So people might say they have hay fever in springtime when all the flowers bloom. Is this affected by personal activity? So sleep, exercise, those sorts of things. Is it emotional reaction? So in menopausal women often who are having hot flushes, I will have them say to me that they are worse when they're stressed or they have an anxiety, and that symptom of the hot flush worsens. Associated manifestations, so sleep disturbance and chronic cough are things that are really commonly reported with reflux. So, okay, I think that gets us through our 7 attributes. So medical and clinical terminology continued. So a disorder. Now it gets a bit blurry here between conditions, diseases, disorders, and it can sometimes be a bit hard to differentiate between them. But a disorder is a disruption of or an interruption with normal functions or established systems. And whereas a disease results from a pathophysiological response to internal or external factors. So, and a disease involves a structure, part, organ, or a system of the body. So it can be quite, it's a lot more specific. So an example of disease would be cardiovascular disease. An example of a disorder would be arrhythmia or irregular heartbeat, and this would be resulting from the cardiovascular disease. Another example would be something like inflammatory bowel disease. So Crohn's disease is an inflammatory bowel disease, and the disorder may be diarrhea or constipation. So that's an interruption with the normal function. Okay, so a condition, an abnormal state of health that interferes with health and well-being. So an example of a condition might be mania, which is seen in bipolar disorder. Syndrome, so this is a set of symptoms that occur together. So they're not related to an identifiable cause, but while a disease is a clearly defined condition with consistent symptoms and an identifiable cause, syndromes can occur as a result of an underlying disease. So an example would be Syndrome X, which is now known as metabolic syndrome. This refers to metabolic imbalances and a cluster of symptoms including high blood pressure, high blood glucose, insulin resistance, high triglycerides, low cholesterol, central adiposity or weight gain around that midsection. And this can be due to genetic factors, it can be lifestyle related, it can be a combination of those things, and sometimes it's idiopathic or there's no known cause for the metabolic syndrome. Another syndrome example would be Down syndrome, which is an extra copy of chromosome 21, but that's in conjunction with distinctive clinical features at birth. And an autism spectrum disorder is an umbrella, and Asperger's syndrome would be an example of a syndrome that comes underneath it. So it's a cluster of symptoms appearing together, such as communication, social difficulty, with normal and above normal intelligence and language skills, which is differentiated from other syndromes that also come under that autism spectrum disorder. Now, diagnostics, tests, observations. So we're looking at things like blood, stool, urine tests, reflex testing, also things like mental health surveys. So using scoring to assess likelihood and severity of depression and anxiety, those sorts of things, they're all diagnostic tools. Okay, so diagnosis is an identification of a disease or condition, and it's also the art of naming a disease or condition. And differential diagnosis is using the information that's presented. So those could be your diagnostic tools, the signs, symptoms, and wondering what could it be. So this is brainstorming the broader diagnostic possibilities and then eliminating until you find the most likely, as then there are so many signs and symptoms mutual to multiple different disease processes. So there's a lot of crossover, and the more diagnostic evidence you have, the easier it is to eliminate the possible options. So differential diagnosis is what else could it be? Now, etiology is the study of all factors that may be involved in the development of a disease. So these could be idiopathic, which means that the cause is unknown. It could also be iatrogenic. So this means it's been caused by as a result from a medical intervention or procedure. So an example of that would be vasculitis, or damage and inflammation of the tissues around an intravenous cannulation. So pathogenesis and pathophysiology are two that are quite tricky. Pathogenesis is the development or sequence of events in a disease process. So, for example, type 2 diabetes. So this is high blood glucose, leads to insulin resistance and then impaired pancreatic beta cell function, hypoglycemia, then to hyperlipidemia, and this can damage nerves and vascular systems, and then that can cause atherosclerosis, peripheral neuropathy, circulation issues, which can then lead to damage to eyesight, ulceration, cardiovascular events. Whereas the pathophysiology, we're looking at detailed physiological steps in between each of those stages of the pathogenesis. So how does that high blood glucose cause insulin resistance? How is the disease process changing the normal function of the body? Now, epidemiology is the study of determinants of the disease. So who is more likely to have this disease? An example would be there's a hereditary blood disorder that affects hemoglobin production, and it's called thalassemia. It's a lot more common in the Mediterranean population. So this is an ethnic marker of epidemiology, but it could also be it's more common in males or females or children. Mortality is the death rate caused by the disease, and morbidity is the disease rate. So, for example, celiac disease is seen in about 1 in 70 Australians. Risk factors. What increases your chance of getting an illness? Risk factors for an example, for coronary artery disease are family history. If you've got a family history, you've got a higher chance of coronary artery disease. Comorbidities, so hypertension and diabetes predispose you to coronary artery disease. Type A personality, so more stressed personality types, highly driven, male gender and advancing years are all things that can predispose you to coronary artery disease. So other examples are immunosuppression, which can increase the incidence and severity of infection, and cigarette smoking, which increases your risk for a number of different disease states. So this brings us to the end of our Lecture 1, Part 1. Here's your readings and resources, and I will be back with Part 2 soon.